Hey, my name is Hannah Cade, and today I'm going to be reviewing the article Persistent Language Delay versus Late Language Emergence in Children with Early Cochlear Implantation. This article was written by Ann E. Gears, Joanna Nicholas, Emily Toby, and Lisa Davidson. The purpose of this article was to compare a group of children with cochlear implants, or CI, who did or did not achieve age-appropriate language scores in mid-elementary grades, and it's also to identify risk factors or persistent language delay following early cochlear implantation. It is well known that cochlear implants often provide great assistance to young children who are deaf and learning to talk. Research has proven that many children who use cochlear implants early in life will eventually achieve age-appropriate scores on spoken language tests. On the other hand, language delays that persist beyond the preschool years are highly predictive of poor reading and academic outcomes. For these reasons, there are unclear aspects that remain regarding cochlear implants, even among children who seem to have very similar auditory history, input, and speech perception benefits. Early language delays may continue or conclude with little predictability. The uncertainty of predicting long-term language delay is even greater in the case of children with congenital severe profound hearing loss. Children with similar language scores before implantation tend to show very diverse patterns of development after being implanted. In order to approach this problem, researchers for this article began by studying longitudinal outcome data in ways similar to literature on chronic language delay in typically developing children without hearing loss. Okay, for the rationale. Researchers pursued identification of early risk factors and current characteristics differentiating early implanted children who experience no language delays, a delay in preschool that resolves, and a delay in preschool that persists to the mid-elementary grades. A previous study completed by Gears and Nicholas on the same longitudinal sample of children provide long-lasting advantages of younger age at cochlear implantation, better pre-cochlear implant-aided hearing, and higher nonverbal intelligence for spoken language outcomes in mid-elementary grades. Researchers in this study compared group characteristics of children with late emerging language and persistent language delay and contrast them with children who achieved age-appropriate language scores in preschool and maintained them into primary grades. This article presents a reanalysis and expansion of the previously published longitudinal data by Gears and Nicholas using the same sample of children. This article focuses directly on the children who are experiencing language difficulties and will attempt to understand who will overcome those initial difficulties and who will not. Researchers hypothesized that very early auditory stimulation and strong cognitive ability would facilitate early speech and language with minimal delays, but that children without these advantages may still reach age-appropriate levels if they receive further improved auditory input for a sufficient length of time. The factors which affect the presence or absence of delays depend on the children's course of development. Children who experience no delay are likely to have higher cognitive ability in the earliest ages of implantation. Children with preschool language delay who receive updated technology and or a second cochlear implant that results in improved hearing and speech perception are more likely to have their delays resolved within several years. Children at greatest risk for language delays that persist into middle childhood years will exhibit early signs of language impairment in their conversational speech and language. Okay, for participants, the longitudinal sample was recruited from participants in a previous study of 76 preschoolers who received a cochlear implant between 12 and 38 months of age. The exclusion criteria for these participants were previous normal hearing or progressive loss, below average nonverbal learning abilities as tested in preschool, and use of language other than English as a primary language at home. 75% of the sample received their first cochlear implant in their right ear. The length of cochlear implant use varied between 7 and 32 months at the time of the first assessment at 3.5 years of age. All children were evaluated 1 year later at age 4.5. The current participants include 60 of the 76 preschoolers that participated in follow-up assessments at summer research camps in Missouri at an average age of 10.5 years old, and these children made up the sample included in this current investigation. About half of the sample received a second cochlear implant between the ages of 4 and 11 years and used bilateral cochlear implants for an average of 3 years at the final test session. 55 of 60 children received an upgrade to newer available speech processor technology in at least one ear between the test sessions, and 42 of them used the most recent processor available at the final test session. The methods included informal and formal assessments in both preschool and primary school. The preschool assessments included a language sample and standardized tests, and the school-age assessments consisted of standardized tests which evaluate language, cognition, speech recognition, and reading. For the preschool language sample, each child was video recorded in a 30-minute play session with a parent at both 3.5 and 4.5 years old. Researchers analyzed the language sample according to the following: number of utterances, number of different root words, mean length of utterance in words, number of different bound morphemes, and speech production. Formal or standardized testing was conducted at age 4.5 to assess receptive vocabulary and global language development relative to hearing age mates. Language tests that were used were the Peabody Picture Vocabulary Test 3rd edition, or the PPVT-3, and this test was used as a measure of receptive vocabulary. Also, the Preschool Language Scale 3rd edition, or the PLS-3, and this was used as a measure of overall language. For the school-age assessment, follow-up testing took place at a mean of 10.5 years old, and the testing battery included language, cognition, speech recognition, and reading tests. So for the language test, the Peabody Picture Vocabulary Test 3rd edition was given again, and this was used to maintain a consistent measure from the preschool assessment. Also, the Clinical Evaluation of Language Fundamentals 4th edition, or the SELF-4, was also given, and it provides receptive and expressive scales. For cognition, the Wechsler Intelligence Scale for Children 4th edition, or the WISC-4, was given, and that assesses cognitive level in relation to hearing age mates and includes a perceptual reasoning scale to estimate learning ability independent of language skills, and a verbal comprehension scale to assess verbal skills. For speech recognition, the Lexical Neighborhood Test, or the LNT, was given, and for reading, the Woodcock Reading Mastery Test Revised was given, and that assesses basic reading skills and reading comprehension skills. Okay, for the results, the researchers categorized the children on the basis of their performance on standardized language tests at 4.5 and 10.5 years of age, in relation to children of the same age with normal hearing from the normative samples. The categorization was defined as follows. Normal language emergence, or NLE, means that the child had normal language scores at both ages 4.5 and 10.5 years. Late language emergence, or LLE, means that the child had delayed language scores at age 4.5 but had scores within normal limits at age 10.5. Persistent language delay, or PLD, means that the child had delayed language scores at both 4.5 and 10.5 years old. And late emerging delay, or LED, means that the child had normal language scores at 4.5 years but delayed language scores at 10.5 years. And the pie chart here shows us how many members were in each group. There were 32% in the normal language emergence group, 36% in the late language emergence group, 32% in the persistent language delay group, and 0% in the late emerging delay group. The distribution of children into normal and language delayed categories is evident in this table, and this is Table 1 in the article on page 160, and it gives us a visual representation of how each group was formed. So, for example, if you first answer the question if the child had a language delay at 4.5 years as yes, you'll be in this row right here. And if you answer the second question of if the child had a language delay at 10.5 years, you'll be right here in this area, and you will be in the persistent language delay group. And this works for all of the groups, and it helps us visualize how the groups were formed. Predicting a child will score within a standard deviation of hearing age mates in primary grades is fairly certain for those children who score within the normal language range in preschool. However, there is an uncertain prognosis for children exhibiting language delay in preschool. They are about equally likely to catch up with hearing age mates. So this would be the late language emergence or continue to be delayed, and that would be the persistent language delay. So that would be this column right here, this row. Okay. Preschool conversational speech language results. Comparison of lexical, morphosyntactic, and phoneme production measures derived from the language samples collected at 3.5 and 4.5 years of age were undertaken to identify specific markers in early spoken communication that might facilitate early detection of persistent language delay. Although performance improved over time for all three groups, similar effects were obtained from independently collected and transcribed conversational samples collected 1 year apart. Comparison of language sample scores for the persistent language delay and late language emergence groups suggests that the later acceleration in language that occurs for the late language emergence group is apparent in a linguistic advantage over the persistent language delay group at 3 and 4 years of age. Children with persistent language delay produce fewer different words, shorter utterances, fewer different vowel morphemes, and a smaller phonemic repertoire. And comparison of the late language emergence and normal language emergence groups results in strong effect sizes even at age 3.5 years, and this indicates that the language advantage of the normal language emergence group was evident at least 1 year prior to formal testing at age 4.5. Standardized language testing results. Late language emergence group exhibited a strong advantage in receptive language and a moderate advantage in expressive language over the persistent language delay group during preschool. All three groups improved their language performance when compared with age mates with normal hearing between 4.5 and 10.5 years of age. However, the persistent language delay group gained an average of only 6.8 standard score points across the three language measures over the interest interval, and this is compared with a gain of 19.5 points in the late language emergence group. The separation of persistent language delay or the late language emergence distributions at age 4.5 years suggests that persistent language delay may be identified early for children with receptive language standard scores more than 2 standard deviations below the normative mean when they are 4.5 years old. Cognitive level was measured on the WISC-4 at an average age of 10.5. Very small average gaps are observed in both the late language emergence and normal language emergence groups, compared with a 24-point gap for the persistent language delay group. This result indicates by reaching normal language levels in primary grades, the late language emergence and normal language emergence group achieve verbal comprehension at or very close to their potential, where children in the persistent language delay group scored far below their nonverbal potential in verbal comprehension skill. Reading skills were measured on the Woodcock Reading Mastery Test Revised, and children in all three groups scored within or above 1 standard deviation of the normative range on basic reading skills, which is within normal limits. So, distinguishing between the categories. The only variable with a significant independent contribution for predicted placement in normal language emergence or late language emergence groups is the age at which the children received their first cochlear implant. For each month increase in age at first cochlear implantation, the odds of being in the late language emergence group increases. And the variable contributing to distinguishing predicted placement in persistent language delay or late language emergence groups depends on the ear that was first implanted. Children who received their first cochlear implant in their left ear and those who received limited auditory benefit for detecting sound and discriminating speech were unlikely to achieve age-appropriate language levels by mid to late elementary grades. The odds of being in the persistent language delay group are reduced when the implant is in the right ear rather than the left. So in conclusion, these results have important implications for professionals who serve young children with cochlear implants. For surgeons, right ear placement of the first cochlear implant should be preferred over the left unless cochlear anatomy precludes placement in the right ear. This, as well as implantation by 18 months of age, may help to maximize chances of age-appropriate spoken language development. For audiologists, encouraging upgraded speech processor technology and working to ensure thresholds of approximately 20 decibels hearing loss when programmed, the devices may positively influence future language development. And for educators, recognition of risk factors for persistent language delay may signal increased intensity of language intervention. And overall impressions, I thought the clinical applications would be the degree of immature speech production and language use during preschool years may predict language difficulties or later. For example, language test scores more than 2 standard deviations below the normative mean at 4 years old establish a significant risk factor for long-term language delay. And my impressions of this article were that the research design was very strong, and since it was a longitudinal study, the researchers were able to detect developments and characteristics of the children with cochlear implants at both the group and the individual level. And these are my references for both the article and the literature review.